Hello everyone. In this class, we'll try to learn about what is pacemaker potential in the heart. The learning objectives would be to draw and label diagram of fast and slow response action potential and give their ionic basis and give the ionic basis of pacemaker potential, explain the effect of sympathetic and vagal stimulation on pacemaker potential. Action potentials in cardiac tissues. Slow response action potential, which occurs in the nodal tissues, that is in SA node and AV nodes. Fast response action potential that occurs in the atrial and ventricular muscles and Purkinje's fibers. Fast response action potential, it has got 5 phases from phase 0 to 04. In phase 0, this is the phase of rapid depolarization and overshoot. As the membrane potential reaches threshold, rapid depolarization occurs due to rapid entry of sodium ions. In fact, immediately above the threshold level of the membrane potential, sodium channels that were activated initially activate other sodium channels, and hence it is called as auto-activation of sodium channels that results in manifold opening of the channels. Phase 1 is the phase of initial rapid repolarization. In this phase, partial repolarization is due to closure of sodium channels, that is cessation of the sodium influx, and opening of the outward transient rectifying potassium channel that causes transient outflux of potassium, which is also going to contribute. So this potassium current is activated by depolarization and is rapidly inactivated. Phase 2 is known as a plateau phase, where as the action potential in this phase remains in a state of sustained depolarization. So this phase is due to sustained increased permeability of the membrane to calcium ions through slowly opening the calcium channels. So that results in slow calcium influx. Efflux of potassium ions contributes to maintain the sustained depolarization. So this plateau phase is much lesser duration in atrial muscle than the ventricular muscles. In phase 3, this is due to the phase of final repolarization. So this occurs due to the cessation of calcium influx and increased potassium efflux. So this phase is mainly due to the opening of outward delayed rectifying potassium channels, IKS. Phase 4 is the phase of restoration of membrane potential. The membrane permeability to potassium is restored towards the resting value. Opening of the inward rectifying potassium channels, IKR, contributes to maintain the restored membrane potential. So these are the different phases of a fast action potential: phase 0, phase 1, phase 2, phase 3 and phase 4. In phase 1, it is mainly because of the influx of the sodium, and phase 1 is mainly because of the closure of sodium channels and opening of the potassium channels. And phase 2, where is the plateau phase, it occurs mainly because of the influx of calcium and outflux of the potassium, where membrane potential remains for the plateau phase for some period. So then the potassium efflux continues, so that is going to lead to rapid repolarization again, and the phase 4 is mainly because of the delayed the closure of potassium ions. Slow response action potential, so which are mainly seen in the SA node. So it has different phases: phase 0, phase 3 and phase 4. It occurs due to the opening of the calcium channels. The depolarization is mainly due to the influx of calcium ions through the long-lasting calcium channels, that is L calcium channels. Therefore, depolarization wave rises slowly. Phase 3 is due to the closure of calcium channels and opening of the potassium channels, that is increased potassium efflux, and that is going to cause repolarization. And phase 4 is the phase of slow diastolic repolarization, and it is also called as prepotential. The early part of this phase is due to the closure of potassium ions, that is decreased potassium conductance. In the later part, it is mainly due to the opening of the transient calcium channels, that is T calcium channels. The calcium sparks, which is nothing but the calcium which is released from the sarcoplasmic reticulum, also contributes to this. So these are the different phases of slow action potential. So initially, the depolarization is mainly because of the rapid influx of calcium, and the repolarization is mainly because of the efflux of potassium. And the fourth phase is called as diastolic depolarization, is also called as pacemaker potential. So initially it is mainly because of the delayed potassium efflux, and the later phase it is mainly because of the opening of the transient calcium channels. So the pacemaker potential, the pacemaker of the heart, that is the SA node, discharges rhythmically and automatically, as we know. The atomicity is due to the spontaneous diastolic depolarization of the membrane potential following completion of each action potential. The resting or diastolic membrane potential that depolarizes is called as prepotential, as it brings the membrane potential towards the threshold level, so which then triggers the action potential. So the prepotential is also known as pacemaker potential. So as we discussed the ionic basis of the prepotential in the initial part, it is mainly because the repolarization phase of the action potential is due to the efflux of potassium ions. At the peak of each action potential, the potassium conductance begins. Towards the end of repolarization, the potassium opening declines, which is known as potassium decay. So at this moment, funny channels open, and funny channel current increases. Okay, so these events allow the membrane to depolarize. So thus potassium decay and the funny current contributes to the initial part of the pacemaker potential. In the later part of the pacemaker potential is due to the opening of the transient calcium channels. The entry of calcium through T channels completes the pacemaker potential and takes the membrane potential to the threshold level, which then fires to form action potential. The upstroke action potential occurs due to the opening of the long-lasting calcium channels. Recently, it has been suggested that calcium sparks, the release of calcium locally from the sarcoplasmic reticulum, also contributes to the pacemaker potential. The contribution of sodium ion is linked to the funny current. Thus, pacemaker potential is largely due to the decay of potassium and the funny current in the initial part, and it is because of the influx of the calcium in the later part. So this is the diagram of the prepotential. Okay, so as we can see in the initial part, it is mainly because of the delayed closure of the potassium, and also it is because of the funny current, that is the ion charges increases inside the cell membrane of the myocytes, okay, which is called as funny current. And the later part, it is mainly because of the opening of the transient calcium channels. So this is the ionic basis of the prepotential or diastolic depolarization. So if you see the effect of vagal stimulation, the heart rate is decreased because of the membrane is hyperpolarized, and slope of prepotential is decreased, that is, it relatively flat. This occurs due to the release of acetylcholine from parasympathetic nerve endings, and acetylcholine increases the potassium conductance and delays the potassium decay. So acetylcholine acts by two mechanisms here, by directly acting on the potassium channels and by acting on M2 receptors. So acetylcholine directly acts on G protein activated potassium channel that produces the G protein, G protein current. So thus it increases the potassium conductance. And while acting on M2 muscarinic receptors, it stimulates beta and gamma subunits of G protein, which in turn activates the potassium channels. So it counters the decay of potassium and hyperpolarizes the membrane during the phase 4 that slows the pacemaker potential. Acetylcholine, also by acting on M2 muscarinic receptors on SA node, decreases the concentration of cyclic AMP in the cells, that in turn decreases the opening of the calcium channels. This decrease in the calcium influx via T-type calcium channels that decreases the slope of pre-potential and takes the membrane potential away from the threshold level. Therefore, heart rate decreases. The decrease in the intracellular calcium concentration also decreases the force of contraction. However, vagal stimulation mainly affects the heart rate rather than the force of contraction, because ventricles have a sparse vagal innervation. Then, effect of sympathetic stimulation. Sympathetic stimulation to the heart increases the heart rate and the force of contraction. The slope of the pre-potential becomes steeper so that threshold level is reached earlier than the normal, which increases the heart rate. This occurs due to the release of norepinephrine at the sympathetic nerve endings. Norepinephrine binds to beta-1 receptor, which increases the intracellular cyclic AMP, that in turn increases the opening of calcium channels and causes calcium influx. The membrane is rapidly depolarized due to the firing level, and the depolarization phase of the action potential becomes steeper. Thus, heart rate increases. The increase in the intracellular calcium ion in the ventricular myocyte increases the force of contraction. Okay. So here you can see this is the normal curve action potential uh, of the pacemaker, and this is the effect of sympathetic stimulation, where pre-potential it the it steepens and the heart rate is increased, whereas in parasympathetic stimulation, because of the delay in the closure of the potassium, okay, so it reaches it is more hyperpolarized, and it it there will be delay in the reaching of the threshold. So that is why the next impulse is going to be late. So that is why heart rate increases with the parasympathetic stimulation. Okay, whereas with the sympathetic stimulation, heart rate is going to increase. So this is in brief about the pre-potential or diastolic hyperpolarization. Thank you.